Welcome back, everyone, to Session 2, Innovative Solutions and Adaptations. I'm Valerie Yeager. I'm an associate professor at Indiana University's Fairbanks School of Public Health in Indianapolis. I focus on public health systems and services research with a particular interest in workforce recruitment and retention. While schools and programs of public health have trained exponentially more students in public health over the last 2 decades, these graduates have not meant higher numbers of formally trained public health workers in governmental settings. And as we saw on the first panel, there are shortages of specific skill sets across the workforce. This is in addition to the general 15% decrease in the governmental workforce as a whole since 2008. And it sets the stage for understanding the Staffing Up Project's recent estimate that an additional 80,000 full-time employees are needed to meet the foundational public health services. Thus, recruitment and retention of employees with training that is appropriate to the work and that reflects the population being served is an important ongoing issue and one that we're going to discuss during our panel today. Our speakers will share innovative approaches to meeting workforce and community needs, from regional sharing of specific hard to recruit roles, to the many roles of community health workers, and finally to public health institutes as a complementary hiring partner that can facilitate a pathway to civil service. Our panel today includes Theresa Magruder, the director of Oak Park Department of Health, a local agency in Illinois, Dave Chosky, the 43rd Commissioner of the New York City Department of Health and Mental Hygiene. Kimberly Fowler, Vice President of the Technical Assistance and Research Center at the National Council of Urban Indian Health. Kusuma Matamala, a Public Health Systems and Services researcher with Program Design and Evaluation Services in the Oregon Health Authority Public Health Division. Sarah Boudreau, a policy analyst for the Oregon Health Authority Public Health Division and Multnomah County Health Department, as well as Michael Baker, health officer of Jefferson County, Oregon. Nicole Alexander Scott, the recent former director of the Rhode Island Department of Health, and Renee Branch Kennedy, chief executive officer of the Michigan Public Health Institute. I'd like to turn it over to Theresa Magruder to get us started.
Hi, everyone. Good morning or good afternoon, depending where you are. I'm Theresa Magruder. I am a doctorally trained epidemiologist and a head of a local health department. And today I'm going to be talking about leadership disparities in governmental public health agencies. I spent my entire career either in state, local, or federal public health agencies, and or with organizations that are that have the mission of supporting governmental public health. And so I started to notice some things throughout my career in public health. And as an epidemiologist, I wanted to research those and see if it was, true across the board or just some things that I've been noticing. And so I'm going to talk about just some general things I've noticed in terms of disparities, and then I'll have some data to back that up. So if we start by looking at the Centers for Disease Control, the nation's top public health agency, and then think about things in terms of disparities, it took over 40 years for the Centers for Disease Control to have its first African-American director of the agency. And then it took probably another it took 50 years before they had their first African-American public health director, and then another 10 years before they had their first female public health director. When we think about, some of the really important things that just happened in our country, on Friday, President Biden just announced that that he's nominating an African-American woman to be the first Supreme Court justice. We have yet to have an African-American woman lead the Centers for Disease Control. We've also yet to have any other ethnic groups besides one Black person and the rest white to lead the Centers for Disease Control. When we look over the last 20 years, we might say that, things are really starting to do better. 9 out of the last 20 years, we've had a female as the director of the Centers for Disease Control. But I think there's still a long way that we have to go before the top leadership of the nation's #1 public health department or leading public health agency becomes more reflective of the country in which it leads. We're looking just at state and local public health. One of the things that we notice is that just in general, governmental public health is overwhelmingly represented by women. Using the PHWIN survey, which is the Public Health Workforce and Needs Survey from 2017, we saw that nearly 80% of state and local public health workers were female. In 2014, we mainly looked at state governmental workforce then, and it was 72% female. I don't think that public health has gotten more female since 2014. I think what happened was that we opened up the data set to include local health departments, and we saw even more of a bump in the female workforce within governmental public health. But this isn't something just unique to governmental public health. We see this in academia, we see this in the nonprofit space, that public health is a overwhelmingly female-dominated career. We also wanted to look at those people who are in supervisory versus non-supervisory positions, and saw that across the board, about 30% or so of the governmental workforce were in supervisory positions. But my question was, amongst those in leadership positions, do they really reflect the workforce in which they serve? So I looked at the 2014 Public Health WIN survey and found that 72% of the workforce were females, but 67.1% of the leadership were females. And to me, that's a pretty good proportion. It's nearly 1-to-1. So that's really something good here that we're doing in public health. But then I wanted to dig down a little deeper, because I know that kind of across leadership, things might look a little differently. So when I looked at supervisor, that front line level of leadership, these are people who might supervise a team. They were about 70% female. Great job. Looking at managers, that next level up, these are people who might supervise the department. This was also 69% female. But once we got to that executive level, that C-suite level within state health departments, only 54.7% of those people were female. So I started to think about, why? What could make up? What could be the reasons that we see really good representation of females at the mid-level and the supervisory level, but not at the executive level? And so I thought, well, maybe it could be a result of education or years of management experience or type of previous management experience. But after controlling for all that, we still found that women were about 45% less likely to make it into the executive leadership positions within state and health departments. This made me wonder about salary. How are we doing in a field that has social justice as part of its foundation, as part of a reason why many people want to join public health? How are we doing in terms of pay equity, especially amongst those people in our leadership positions? And I found that amongst the highest earners at state health departments, women were 36% less likely to make it into that high earning category, regardless of their leadership level. So this really kind of wraps up what we're seeing in terms of leadership disparities, is that women are less likely to make it to that top level, And even once they do, they're less likely to be paid on par with men. And it's really makes you wonder, especially in a field that understands the impact of disparities on health. It understands the impact of even socioeconomic status on overall health. What is it that we are willing to do amongst our workforce to ensure that women are given opportunities to rise to the highest levels, making sure that our voices are at the table, that we are part of those who are having the final decisions when it comes down to the health of the community, since we represent that in the workforce at nearly 72% or more. I also mentioned that I am an epidemiologist, and the roles that I've played in the majority of the health departments that I've worked in was leading epidemiology teams. And so one of the things that Valerie mentioned when she kicked us all off is that the amount of people seeking public health degrees has risen, but the amount of people with public health degrees in the workforce has actually decreased once we look at PHWin surveys from 2014 to 2017. We started with 17% of the public health workforce with a degree in public health. And in 2017, we were down to 14%. And while I'm not one to say that I think all state and local health departments need to be staffed with, 100% of people with MPHs or public health degrees, that's not what I want you guys to take away from this. But I do think that there are specific things that are taught in public health programs that local and state health departments may not have a good representation of, because we don't have a good number of people within our organizations that have public health degrees. And one of those things is really health equity and prevention. I think those are pieces that are lacking in a lot of our health departments, at least the framing around health equity, the framing around leading with prevention are really two things that I feel are missing. And then lastly is kind of that epidemiology skill set. And as I mentioned, I've led a few epidemiology departments, and I also did a study using the 2014 PHWin's data. And one of the questions that we looked at was, what is something that the majority of epidemiologists don't know how to do for their daily work? And we had a list of like 16 questions there. And overall, there were about a third of those daily tasks, things that epidemiologists said they do on a daily basis, that they said that they felt unprepared to do or untrained to do. And so I think that I know that there's going to be another panel coming up later on this afternoon where we'll get to hear about training gaps and capacity of the public health workforce. And this is one thing that I want you guys to keep in mind as we move forward, that our epidemiologists are coming into these local health departments and they don't have the skills that they need in order to do the work and carry out the needs of the community. One thing that I have done personally is that whenever I go into a new community in a leadership role at a health department, I always connect with my local university and say, these are the needs that the local health department has. Do you have curricular geared towards this so that I can have a pipeline? I can have a place that I can reach back to when I'm looking for new staff to fill and build our health department. So I think that there's always room to have those formal and informal connections. And I know that all these things will be talked about more later on this afternoon. Thank you.
Thank you, Theresa.